We're going to go ahead and get started with our program. And I'm going to have Seton get out the way of the camera right here. Actually, I'll move back a little bit. All right, good afternoon, everyone. Thank you for coming. My name is David Boyd. I am the Assistant Dean for Recruitment and Admissions for the UIC Honors College. The Equity, Diversity, and Inclusion Committee of the college welcomes you to its inaugural Flames for Change speaker series, where we're going to discuss a range of topics based on the interests of our students through the greater UIC community. Tonight's edition is titled Flames for Change, Confronting the Migrant Crisis and Homelessness in the City of Chicago. Before we begin what should be an informative discussion, would the members of the EDI committee please raise your hands? Fantastic, so much. Yes, and you too. Okay, great, thank you so much. We have worked hard for several months on putting together this program, and we think, once again, it's going to be something that's really of interest and a timely topic of discussion. Let me first go into the purpose of the Flames for Change. The goal of this is to actually foster change agents in a particular discipline while, of course, employing EDI principles that do two primary things. First, to combine the ideals of enthusiasm of students with alternative pathways and perspectives in certain disciplines. In other words, to bring in working professionals who are trained in their field to speak about innovative and non-traditional ways that students can utilize their academic pursuits to better highlight and interrupt and resolve systemic issues. Second, to take a student's long-term aspirations and develop them as members of the UIC family, but to also connect them to individuals who are doing this kind of work that makes a difference. We want to help harvest, develop, and prepare talented UIC students for a more complete and comprehensive professional life that educates, engages, and encourages the best that they can offer. This form of leadership would be considered inclusive, given that it requires everyone to create an environment that is involved. So what is inclusive leadership? Very briefly, it means that the leaders that are committing to ensuring all team members are treated equitably, feel a sense of belonging and value, and have the resources and support that they need to achieve their full potential. There are 7 acts of inclusive leadership. Whether students are just beginning their studies in college, are considered seasoned members of the UIC community, or are actively engaged in organizations in their area of interest, engaging in these 7 intentional acts of inclusion and building their leadership competencies will allow them to reinvent and strengthen their relationships. First, to deepen student self-awareness. Second, to foster social awareness. 3, to reveal any blind spots in thought and in action. 4, to listen to understand, to become a good listener so that we can better understand each other and do great things. Number 5, to create connections with one another. 6, to lead with courageous vulnerability. And 7, to invest resources in inclusion. A primary goal of the UIC Honors College should not just be to promote, develop, and provide resources for future change agents academically, but to also show how academics can create leaders who replicate principles of EDI leadership in action. This could inspire our students to be demonstrative in utilizing their education in non-traditional ways and meet the critical needs of a greater society. So once again, on behalf of the EDI committee, the Honors College, and UIC, I want to thank you for attending today's event and look forward to seeing you in future events. And of course, be sure to bring someone with you. Thank you.
Thank you, Dean Boyd, for that wonderful introduction. Hello, everyone. My name is Yaman Nandolia, and I am a computer science major here at the University of Illinois, Chicago, and I'm minoring in business administration and math. And with the Honors College at UIC, I'm connected as a teaching assistant, as a student, and also as an ambassador. It is a pleasure to have you in our audience today, and also if all the souls in our live stream. Thank you so much for your time, and I look forward to have a good discussion with you and the panelists.
Hi everyone, my name is Arya. I'm a second year public health major and I have a minor in biology and a minor in chemistry. I'm also involved with the Honors College as a student and as an ambassador. I'm really excited to hear from you all today. I've been grateful to see all the work that the Mobile Migrant Health team has been doing these past few months. I'm really excited for our discussion.
Great. I'll introduce myself too, and I'll probably pass the mic back. Hi everyone, I'm Kelly Bauman. I'm a second year MPH student at UIC also. A lot of UIC faces. I've been involved with the Mobile Migrant Health team since July of this past year, mostly in like public health and creating community connections, capacity. So yeah, happy to share the work we've been doing.
Hi everyone, my name is Sarah Cooper. I'm a fourth year medical student at the UIC College of Medicine. I have been founding board member for about a year now at MMHT and been participating in the ever-changing and ever-growing sort of presence that I've been so lucky to kind of humbly participate in and help with. So I feel excited to answer more questions.
Good afternoon, I'm Evelyn Figueroa, she, her pronouns. I'm a professor in the College of Medicine, president of the medical staff at the hospital, and I also run an anti-poverty nonprofit, the Figueroa Family Foundation. We are the incubator for MMHT, and I serve as the principal faculty advisor for this wonderful group.
Hi everyone, my name is Monica Padilla. I'm an undergrad student here at UIC, majoring in biology and public health with a minor in Chinese. I'm also a part of the Honors College, so it's nice to see familiar faces. And within MMHT, I'm their logistics and scheduling coordinator.
Perfect, thank you all for joining us today. We're just gonna go ahead and start off, but could you guys please start this discussion by providing some context and an overview of the current state of the migrant crisis in Chicago from your perspective and experience?
I can start by doing a little bit of history, and then maybe you could take on how MMHT was founded and stuff like that. So August of 2022, Chicago started receiving buses of migrants from the US-Texas border, sent by the Operation Lone Star, and over the past, it's coming up on 2 years now, it's continuously brought more and more people, primarily from Venezuela, also Colombia, and Haiti to our city as new arrivals with varying immigration statuses, but the one thing that's most clear is that people really need a lot of help and support when they get here. That's where MMHT and truly hundreds of other organizations have stepped in. We came in when people were living in police stations, so in January of 2023, there was just no more shelter space available in Chicago, and the city decided to temporarily house people in police stations. For a few months, it was just several hours, and then as the shelter spaces just got so clogged up, people were living in the police stations for days, weeks, or even longer. So MMHT stepped in to help provide some care, and many other mutual aid groups or community-based organizations were providing a variety of services completely free to people at the police stations all across the city. And then in December, all of the people living in police stations were moved to shelters, and we started instituting shelter stay policies and things like that. So we're in a period now where most people are in shelters or in apartments, some rent subsidized, some not. And we're anticipating there will probably be more evictions from shelter. We don't know where people will go. Hopefully they have some connections or have been able to find a place to live, but it's still pretty uncertain right now. And then we're expecting, if it follows the trend of last year, we'll get a lot more buses in this summer when people can live easier outside. So that's a little bit of what's going on from a high level.
I'll briefly pick up and just explain some of the needs that were or were not being met at the police districts, and then where Mobile Migrant Health Team sort of filled a particular need. There were already, like Kelly mentioned, hundreds of different either individuals or organizations of individuals who were providing sort of the basic necessities just in a truly Good Samaritan sort of a way, whether that was food, clothing items, trying to just kind of make sure that there was enough to go around. But one thing that Mobile Migrant Health Team was sort of designed to implement was the routine or triage or urgent care level medical concerns that were happening at the police districts. The kinds of over-the-counter medications that you and I might take for granted in our book bags is just something that it was not available from a financial point of view, and also from there not being access truly to the sort of network of support in the greater like police district fashion. It was really just a space that was being loaned out, and not like a full sort of array of services being offered from within that space. So that was one of the main things that the Mobile Migrant Health Team was focused on. That and making sure that as individuals who were ill could not become more sick, progress to something that was emergent, go to the emergency room for something that was essentially easily preventable or easily manageable from a like routine health care perspective. We've participated in run-of-the-mill things, but we've also seen and prevented larger, more concerning issues. And I think part of that has really just been that we were a constant presence starting in, I guess, April, May of last year, coming up on the year now, May. We were doing ad hoc 1 to 2 times per week, and then we sort of very regularly dedicated ourselves to a specific section of the police district so that there was continuity, so that there was a reliability for our patients to know that we were coming, for us to also be able to follow up week to week and provide some sort of medical home. And that's sort of where our journey is continuing to progress now.
38,500 people have come from the Texas border since late August 2022. As of today, we probably can't account for about 10,000 of those people who came to Chicago. I was looking at the dashboard from City of Chicago yesterday, and there's some pretty glaring gaps, and we don't know where people are. And there's some short, medium, and long-term needs that people have when they get to Chicago. If you do a little bit of history learning about it, and I'm not good with geography, I'm actually quite bad, so I have to pull up maps all the time. Venezuela was a country that had a lot of oil money, that was a very rich country at some point, that had a lot of socialist principles, and basically due to a lot of corruption and hyperinflation of the economy, which occurred because literally people in Venezuela, or the treasury, printed more paper, so printed more money when they ran out of money. They devalued and destabilized the entire country, and 20% of Venezuelans have left their country in the past decade. So to understand, it's really important to kind of look at a global level of what happens when one part of the world becomes vulnerable, everyone is more vulnerable. Now we're not, although we feel like we are the ones that are most inundated by the Texas border, Colombia is actually the country that's most inundated by it, and about 25% of people that have left Venezuela have just stayed in Colombia, which is not a country that can afford that. Basically everyone in Venezuela is unemployed right now, and a very typical wage, a daily wage, would be a couple dollars if you're lucky, and things are not free over there, so they have a shortage of lots and lots and lots of things. And I needed to contextualize this when I was doing the work last year, when I started looking at pictures of the Darien Gap and understanding how you would leave your country. And I understand a lot of the narrative is about Venezuela because 75% of the new arrivals from the Texas border are from Venezuela, but the stories are very similar regardless of where people are coming from. They're trying to escape extreme poverty and all the things that come along with that. So inadequate housing, inadequate healthcare, and education, of course, dries up. This is a country that used to have very, very high educational attainment level compared to the rest of Latin America. That doesn't exist anymore. More people would finish college than basically anywhere else in Latin America, and that is gone now. So folks are walking thousands of kilometers and going through this, and the people that are leaving are the people that have the least, but that have enough to get through. When they get through, it takes several months, and that's where the community-based organizations come in. You're really finding people that are at the intersection of exhaustion and desperation, while they are completely ignorant to American practices and getting basically trafficked through our country, which we legally sanction, but this is what's occurring. Chicago, we've seen a ton of people that are living on the streets in Chicago that are new, but this is not a new problem in Chicago. We all can't agree that homelessness is not okay in Chicago. We live with it every day. A point in time count in Chicago typically has about, prior to the Texas border crisis, had about 5,000 people living out, in emergency shelter spaces and outside. And this has exacerbated that situation where we've really divided up social services from healthcare, and we very much marginalized. So we have this huge influx of people experiencing homelessness, and then we've basically reacted to it in the most expensive way and non-sustainable way possible. At the peak, the shelters had about 4 times as many people as the emergency bed count prior to this. We had a similar wave of difficulty housing people during COVID, the first wave of COVID, when we had to space everybody out. And we asked, those of us who run CBOs, asked a lot for the city to put in more infrastructure. You may recall that our mayor, less than 10 years ago, Rahm Emanuel, took apart a lot of the Board of Health clinics and separated healthcare even more from public health, because the expansion of the Affordable Care Act made people think that we didn't need that net. And so we really dried up that net. And even though 10% of everyone in Illinois is still uninsured, and then you have millions of people who are completely living outside of that, because we rely a lot on Illinois and with undocumented folks for work, etc. We really just have poked the perfect storm in Chicago, where there's this cascade of getting people here who have newly arrived, who are in general very young and healthy, but just like everybody else have disabilities and need those things taken care of. And why wouldn't you try to come if 90% of Venezuela is living in poverty, and 50% of them are food insecure, and 85% of medications are in shortage in Venezuela. You would do everything you can to protect your family. So you think that going through the Darien Gap is the worst thing you're going to do, and treading in water and being covered in mud and losing all your belongings and getting robbed and seeing someone get really hurt, or you getting really hurt. And I mean, the stories, the trauma that the MMHT has faced during this has been, the bystander trauma has been enormous, and the sense of helplessness that we've had, because we in a very busy, loud police station, it's very difficult to provide trauma-informed care. So we've been taking care of folks that really are at their wits' end. And then there's a lot of rhetoric that we've been dealing with in the community, where folks really don't, everyone's immigration story is different. Cooper's an immigrant, my family's migrants, but a Puerto Rican migrant is very different than a Venezuelan to Canada migrant. They're very different categories, and unfortunately we've jumbled all these words together: asylee, refugee, migrant, temporary protected status, humanitarian parole, undocumented. There's so many different categories, and that's the problem with immigration. It's all getting all sort of muddied together. For the folks that they call asylees, these are folks who have a year to say that or to make a case, to start their paperwork, to make a case to stay, based on persecution that threatens their lives. So you can't say, it's really poor, and because it's really poor there, I'm going to die sooner, which we know is true, but you can't say that. And so you have to make a case. But remember, if you are lacking agency, which most of these folks are, and lacking the money, and don't have records, you have to prove your whole case. So you come to Chicago, you got through the Darien Gap, you waited in Mexico for the lottery to get into the United States, because that's what it is now, and there's a certain number of people who are allowed to interact with the border patrol every day. And if your number doesn't come up, you just sit in limbo for months and months and months. And I didn't mention you have to be digitally notified that you can go and interact with Border Patrol, which means that if you can't afford a phone, which how would you afford a phone? You're living in a tent in a Mexican detention center. So you get there, you finally get through, or you sneak around and come in unauthorized, which carries its own treachery. Then you get to detention center in the United States, then you get trafficked to another city, and then there in that new city, you're kind of at the mercy of whoever's there. Now you're gonna be a resident in 2 seconds. You're gonna be a resident in a few years, Kelly. So I was a residency director, and I hate to belabor this analogy, but I love to use it. For you, you're gonna say you're ready for residency, right? You're gonna say you're excited for it. They always say this, they're like, I'm so ready, I'm gonna do all the work that needs to get done. Are you thinking pre-med? Of course you are. So they're gonna be like, I'm ready for it. I'm so excited. Think about the person you knew who got married, and they're like, this is gonna be the best day, and then it's like a disaster, and it's hard, and all of this. And I think that that's a lot of the stages of grief that you see the migrants experience. They think the Darien Gap is the worst. Then they think getting through Mexican border is the worst. Then American, detention center. Then getting on the bus. And then all of a sudden you're part of 2,700 people in a police station with one porta potty, like it was at D12. So our org was the hub for D12. So we mobilized a lot of supplies and just the most basic of things you couldn't imagine. And these were the things that MMHT, besides triaging primary, urgent care, chronic disease, besides making sure people got the care that they needed medically, if you didn't deal with the social determinants and the political determinants, because those people were not going to be able to organize into short, medium, and long-term goals. They wanted everything right now, which I don't blame them for, because remember, it's not just like getting on, like I went to Mexico City 2 weeks ago and it took me 5 hours to get there, right? Like these folks take 5 months to get there. So by the time they get here, their family is desperate for money back home. There are all these things happening. So it's just been this whole avalanche of understanding needs. And even though our org is very migrant friendly, we're at Ashland and 21st for the Pilsen Food Pantry. New arrivals are completely different than people that have been here for a long time. And then the xenophobia, the language barriers, Venezuelan's not the same as Mexican Spanish, the food, there's so many different things. So we've helped at multiple different levels, my organization, from helping run shelters to organizing supplies. We have a free store, we have the food pantry, and then in addition, we're trying to make sure that we're providing culturally responsive care through MMHT. And I can never regard MMHT highly enough, just the amount of work they've done. And now that the police stations have closed, the biggest volunteer medical group has been helping with outbreak response team, because as you can guess, congregating 2,400 people in a building, which is over twice as big as any New York shelter, posed more problems than people thought about. But what I think is really interesting about all this, and for those of you that are hoping to go into policy and changing things, is just like the cliche saying that the system is working exactly the way it was designed to work. And I was with the American Medical Association this morning, and we were talking about migrant health, and they said, well, why is it like this? And I said, because they don't want it to succeed. Of course that's why this is happening. Like, why else would it be happening? If favorite staffing is making, gosh only knows, like how much money favorite staffing is making, and yet we're sitting here like hamsters on a wheel, like trying to respond, and it shouldn't be responsive. This morning it leaked out that there's a TB outbreak. Well, that's not surprising. We know that if people are in close proximity to each other, that it's easy to spread. We know that happens at Cook County Jail all the time. So how is this different? And yet here we are again reacting to it. So for me, all this work has really helped me just think about what's important to me, and that's about just the basic definition of humanity and like, what do we all have a right to? And are we going to do anything about all the people that were homeless before the migrant crisis and the people after? Because we could really learn from this and build something better instead of just spending billions of dollars and not having another outbreak. Because we've had varicella, norovirus, measles, TB. I mean, you can name thing after outbreak that we've had, and none of these things are surprising, and yet it makes no sense to me. And then the city's dependence on community-based organizations to pick up the slack, but the community-based organizations were not at a security level to know what's happening. It's kind of like being at UIC, right? You don't have your clearance, you don't know why it's happening like that. But you feel very badly because there's so much consumerism and excess in the United States. Like, there really is enough to go around if you decide you want them to be around. Sorry, I'm kind of cynical. Sorry,
Oh no, it's okay. I have nothing to add. I was throwing it a little bit. They did everything perfectly.
sorry.
Thank you guys for all those amazing responses. Could you kind of provide, I guess, a timeline for when your organization first started working with migrants and how and why you personally got involved?
Do you want to start with that?
Yeah, I'll start.
Did I turn it on?
Oh, yeah, it's this button.
Here.
Oh, sorry, I'm really bad with technology.
Let's try this one. I think it's fine. So the very first health run to a police district was May 8th of last year.
May 8th.
Coming up on 1 year there. I personally got involved in the midst of my third year clerkships because I also am from Caracas, Venezuela. I was born and raised there. I am lucky enough to, by sheer dumb luck, my dad also is a Canadian citizen, and it just got conferred onto me. It made several other things more simple than my peers and old neighbors sort of journeys, which is who I'm really seeing in a day-to-day basis with MMHT. And I think that the reason that that I got involved anyway, beyond just like that personal connection, and beyond just a lot of what Dr. Figueroa was talking about ringing true, which is the fact that there are so many things that are so commonsensically necessary for every single human and are not being provided or worked toward some sort of equitable distribution in this like land of excess and land of yes, freedom, and land of, to a certain extent there's lots of opportunity, but the withholding of that opportunity is something that I've seen and I think needs remedying. So this was a small chip in a larger puzzle that needed to get fixed. And I still think that I still come home after runs or after this whole year, this entire journey, and I'm constantly thinking that it's not enough, and I'm constantly upset with the doors that are initially slammed in our face, and then someone holds it open just a crack so we can listen in a little, and we can make adjustments, and we can start preparing better if we were just more collaborative, if we were just more open, if only we weren't providing care in such a siloed way. I've never been in a city with as many medical districts in sort of 40-mile radius as Chicago, and still to have an issue in continuity of care is something that is it was very strange to me when I first saw it. So that's kind of one of the things that has been an underpinning in terms of my continued presence and my hopefully still continued presence. I'll be sticking around in Chicago, so I'm looking forward to that, I guess, too.
Yeah, I mean, I had been just kind of reading about the migrant crisis, and when I'm going on a run and I pass a police station, I see people, it was like, there's just such an obvious public health humanitarian issue like right on my doorstep, and I wanted to get involved. So I actually found out about MMHG through Instagram. So shout out to our Instagram coordinator, Jenny. And it was, I just sent a message. Within a week, I was like on the ground getting involved, helping out with any and all background tasks that were necessary. And that, just being on a run, I think the first thing I noticed is how like similar I am to a lot of our patients. We're all pretty much the same age. Most people who are coming are mid-20s like me, and like I just putting myself in their shoes was like dumbfounded by what they had gone through, and that's really like driven me to keep helping like day in and day out. And there's so much that goes on during a run, but also after and between. So I've just tried to make sure that I can be as much help as possible.
Mobile Migrant Health Team is the brainchild of Sara Izquierdo, who's not here today. And Sara was introduced to me by email in early May and was basically pitching her idea to any faculty at UIC, any physician that would listen. And then someone thought that we should meet, and we met and started packaging packs of over-the-counter medicines and labeling them, because I had done something similar at Pacific Garden Mission when we sheltered in place during the first wave of COVID. PGM's the biggest shelter in the Midwest with 950 beds. It's around the corner from here. It's the big sign with Jesus Saves, and so we were in there sheltering in place during a very large 70% cumulative COVID outbreak, and we basically sheltered there to not overwhelm the hospital system, since these were healthy people. They had mild COVID, so they didn't need to be in the hospital, but we had nowhere to isolate them. So I worked with CDPH, and UIC let me off the hook to go do that. So someone thought we'd be a good pairing, and I'm kind of one of those people that doesn't think through things very far. So I saw Sarah's enthusiasm, and I said, sure, you can do that. Here are all the rules. These are the things you have to watch out for. Here we have this, you can use anything from our organization, but it was really Sara putting on her, jetpack on her back and just fearlessly going. And that day, a news crew happened to be at my house and taping about migrant response, because the press is really the way you get a lot of this attention for anything, is getting the press to cover it. And even though there are a lot of people that are very negative about migrants, I think there are enough of us that understand that this is how this country was built, and that there are basic human rights that we should all have, regardless of when we entered into the country. And people like Sara and Cooper and Kelly, these are just folks that really talk the talk and walk the walk. And so we started running around to police stations, and if you know me, I will sucker anyone into doing something. I have physician friends. I will say, my poor husband, who's a shy family doctor, got forced to go on one of the runs with them because I ran out of time that day, so I lent him out too much, but I do, and he's okay. He's so, but it was really Sara's idea, and eventually CDPH relied on Mobile Migrant Health Team more than anyone else. They were the most prolific volunteer team. This little engine that did nearly 10,000 visits, still accompanies. I send them complex medical cases that I want them to take care of, including that guy that you may have heard about that had transverse myelitis and is in a wheelchair and can't get into his house. And MMHT has gone and organized a ridiculous amount of stuff for them, and the G-tube child, and the guy with the traumatic brain injury that's now going to rehab, which is really nice because they were going to discharge him to the street. And there's a lot of advocacy that MMHT does to bring attention to these cases, and to understand that we can't leave people like that, and that even if you decide to leave them like that you're going to pay in a very expensive way, reacting anyhow. So they started doing their runs in May. They were running at least 6 runs a week during the summer. We tried very hard to get CDPH to keep us on a schedule and to not have us running to District 3, which is Cottage Grove and 71st, on the same afternoon as Rogers Park. These logistic things show how much work we need to do just to organize our public health response. I think it's gotten better, but that was really with us inserting a lot of the structure for them. And remember that also the mayoral administration was turning over. Not everyone wants to see these things succeed, so there's just a loss of best practices and institutional knowledge that we all keep experiencing. But in spite of that, they keep showing up to do things, and as we mentioned, the shelters, the police stations being used as welcoming sheltering stations, that changed, and now people are all in brick and mortar until they are not allowed to stay there anymore. So we're doing our best to support folks. In spite of that, the city really doesn't let community-based organizations interface very much at shelters. The Pilsen Food Pantry is a mile from the Halsted shelter, so people walk there. We've experienced ridiculous numbers of people coming for food and also for other supplies. We have a free store. Our free store experienced 500% growth last year for a weekly volume. We used a busy day at the free store used to be 30 people, and it is routinely between 60 and 150 people that come to get clothing, bedding, housewares, other stuff. Our organization only has 10 employees. 4 of them are full-time, the rest are part-time. So we're very fortunate to have built a model that depends on the community and that the community depends on. So we have lots of volunteering, students of all levels, internships, et cetera, that pay into that system and help out because it's very much a mutual aid approach. We're here when you need us, and if you can help us, we'd like you to help us. The other shelter that's very large, that's not far from there, is Walnut Shelter, which is 300 North Ashland, because that's where Walnut is, so by Lake in Ashland. That's one of the other ones that still hasn't closed. I don't know if you know that a lot of the shelters are in eviction processes now, that now it's gone down to 60 days. There's no rental assistance that is available for anyone that entered after mid-November. And even if you were able to get rental assistance, you can't really get a credit check or prove that you can earn money because you have language barriers and all these other things. So even to get someone to rent to you is very, very challenging. So that's been a huge barrier. So we continue to be, besides being asked about medical needs, clothing, food, people are constantly asking for work, but remember, it's a felony if I help somebody work. So I can't pay someone under the table. It's really a very complicated, antiquated system that we have for immigration. Regardless, we're doing our best to keep showing up and doing what we can to provide services to help families stay together and to get used to being in the U.S. and help them over the hump.
So from an undergrad perspective, one day me and my other friend, we were added into a WhatsApp group. And this was when shelters were, so I joined 2023, June, July, and we were going to shelters as well, a very small amount. And in the beginning, we just went there to supervise the shelters, make sure all the needs are met, non-health needs. And by chance, Miguel, he was there asking for a chair, like if we had a chair, because they're doing health assessments outside, and we asked how we could be part of it. So I'm not a medical student, no skills there, not a physician, but I do know Spanish. So one way that me and Diane helped, we went to go do medical translation in Spanish, and we were also scribing. But the difference in being inside a shelter where there's not full occupancy to like going to a police district outside where you have people outside, people inside, it's very different. So I could say that it's interesting how you want to help as much as you can, you want to go above and beyond, but with your skill set, like I'm still an undergrad, right? So there's nothing much I can do other than really help translate, help scribe. And I went through like the whole process as well, so we were doing like taking our notes on paper, and then we went to RedCap, and then we went to like having different systems and methods continuously evolving. But if there's one important thing is that undergrads, I see one now that has joined us previously. Like we do clothing drives here at UIC, part of Mujeres en Medicina and Medicina Scholars. We have done clothing drives in order to try to support with the food pantry as much as we can.
You're a medical assistant though, right?
Oh, certified nursing assistant.
See, don't sell yourself short. Yeah.
Yeah, close enough.
Thank you so much for sharing, and we really appreciate the good work that you put in. But with all this negative sort of circumstances for the migrants and also for MMHT and with everybody else in this community, it would be very insightful for us in the audience, the change makers that we have here, and also for the future for our community to know from MMHT's perspective, some of the specific success stories that you could share with us that could help us understand the factors that lead to that success, so that we as a community at UIC and also in Chicago can foster those factors or foster those sort of initiatives that we can take going forward to ensure that we also support that success that MMHT is experiencing.
We have no shortage of success stories. It's just trying to find a good one that comes to mind.
There have been 15, I'm looking at the dashboard from yesterday, there have been 15,763 individuals resettled. This is a huge number. There's also individuals reunited with sponsors. That's different, right? Because if you're a refugee, you have a sponsor when you're, or if it's a work visa, you would have a sponsor. The folks that are coming with asylum are arriving, and then you're trying to find people to attach them to that are relatives. Remember, if you're coming from a country that is anything smaller than the United States, you're thinking that Denver is right next to Chicago, is right next to DC, because it looks close on the map, but it's not close at all. So, so there's a lot of reunification that occurs. But the really nice thing about this is that there are a lot of folks that really are moving through the system. Now, I know that the temporary work, the work permits take at least 150 days after you complete your asylum application. What I've seen it turn out to be is more like 8 to 9 months for a work permit, and it costs something. But I've seen quite a few people get through that at this point. A lot of people that are getting things together and moving it along in life. The other part I think it's really nice is to think about the folks that we really overlook the most. I think in a capitalist society, you think a lot about getting people to work. This is always the thing about homelessness. People always say, oh, if we can get them housed, they can get back to work. And you're like, well, not everyone that's homeless can work. Sometimes the root cause of their homelessness is their serious mental illness or a physical disability or traumatic brain injury, which is in 50% of people with chronic homelessness. So I think that sort of that ableist lens, I've been very happy that MMHT has helped me look at that a lot differently, and to think a lot about, is it okay for someone to come into a country if they aren't going to be ever replacing the aging workforce? If it's someone that's just ill, that a family really wants to help. A lot of children with some pretty significant developmental problems that were carried across in horrifying conditions. I think it would be nice for you all to talk about the boy with the enteral, and Bumblebee, I think it would be great to highlight it.
Sure. So I think one of the success stories that has a place near and dear to us because of the fact that we saw them at the very start of their journey, meaning with nothing settled, with a significant medical condition that essentially was causing a need for a G-tube, but then the tube itself had become dislodged. And so if you don't know what a G-tube is, it's a tube that goes directly into your stomach, as opposed to, because you are unable to take food by mouth. So infection risk aside, in terms of getting across this journey with a physically external sort of component to like your feeding process, it became dislodged, and then it was a matter of finding a replacement to this tube, trying to get them to appointments at specialty care, which even for insured individuals with long-standing citizenship is incredibly difficult and can be a months-long process. and trying to find definitive treatment, because all of this process was really just kind of a stopgap to finding a definitive surgical component to the treatment process for this child. And there were several wins. I think one of the wins was finding the 14 French G-tube to replace it. I think the second part was actually also having enough enteral nutrition, so like the ensures and actual nutrition to give through that tube, because there was a period of time where this child's family was essentially mixing up cookies and milk because that's all that they had available in order to have something liquid and something to provide for their child. And then the third sort of success, I think, further down the line is in their own apartment. I think it's rent subsidized, I believe.
Yeah, they're in TPS.
Yeah.
Sorry, East Rep.
And also getting them enrolled into WIC. The entire process back and forth still, with a lot of patient advocacy involved in terms of getting them to their appointments, getting all of the other chronic issues under control before surgical management can even be considered. It's an ongoing process. I'll be the first to admit that it's very frustrating that he still hasn't gotten the definitive management and that there is still so much left to do. But I think back to a taped together, truly makeshift situation, feeding tube, with a bout of pneumonia in between and a significant risk of infection and all these different things, comparing to where they are now, and it really is quite special to look back on. And they're a wonderful family in general too.
Yeah, it's a good story. I also want to provide some additional context. And Dr. Kathleen Arnold is a political science professor at DePaul who's done a lot of research, specifically on the political situation and how that intersects with health. I mean, the situation that a lot of our patients are arriving in is they've had no, or maybe one appointment for medical care in many, many years. And so for anyone who has any sort of chronic issue or even minor issues, they're coming to us with a pretty advanced illness. So we're meeting them at a point where they have nothing and their illness is oftentimes at a critical point. So I'm thinking also of our patients. We've met some LGBTQ plus identifying patients who fled specifically persecution for their identity in Venezuela and other countries, and they're coming here often with existing chronic illness, but also to seek asylum and mental health support too. So sometimes we're the first people who have asked them about what their needs are beyond, do you just need ibuprofen today or something like that. So being able to match them up with providers in long-term care and housing that is safe for them is really important, and I feel honored to have been able to be a part of that too.
I think what's really interesting to think about is the Ukrainian migration crisis where almost 30,000 people came to Chicago and were absorbed very differently than this. This is a city that always has waves of immigration that's just are in our DNA. This is what we've been doing forever and ever and ever. And to really look at how differently the response to this has been is important to note. To notice that all of a sudden the inn is full and that there's no room for people when we have an out-migrating population of workforce of Chicago, when we have a lot of vacant properties, when we have not figured out a way to hold the Chicago Housing Authority accountable for vacancies that are not turned over in a timely fashion. For me, it all just keeps boiling down to us really defining what being a sanctuary city is and what are the basic needs that everyone should have. What are the things that we should all be able to rely on? Should air be clean? Should we be able to drink clean water? Are these acceptable? Is that the floor? Because I think it should be. Clearly, healthcare. There's a lot of national debate and continues to be, and that's where I think we need to speak up and talk about what the costs are when we don't do it that way. There's a really iconic health affairs slide that shows the gross domestic product of how much is invested in healthcare and how much is invested in social services in different parts of the world. And it correlates with life expectancy. And it's so fascinating, right? Because the more you invest in social services, the longer everybody lives. And it's not just living longer like on a ventilator. These are people that are living a better life. When your life expectancy is 63 in Haiti, it doesn't mean that you wake up when you're 63 and then you just fall asleep. You have a bad death. It's not an easier way that you die. You die a much harder way. And that's really what we're interfacing with MMHT, are folks that are really desperate to make their lives better, people that have brain cancer, people that have uterine cancer, people that broke their leg in 5 places while they were crossing the Darien Gap, and still are trying to get their family to come with them because their family has nothing to eat back home. Or the preacher who had repeated death threats because he was part of an anti-drug campaign. I mean, the stories like break your heart, because people are really in their most desperate and vulnerable states, but really are still optimistic and wanting to see the good. I mean, I can't tell you how happy I was when we got a half pallet of Pediasure donated to the pantry. I immediately reached out to he has a really hard to pronounce name, but the child with the G-tube, and also I can't use his name, so please don't think I am objectifying him, but I remember immediately sending Sarah Skelgo, like, we got a half pallet, we're putting it aside for the child. Because the other part of it is kind of sustaining this. At the Pilsen Food Pantry, we really try to get the right resources into the right hands. There's so much waste and excess. So really you're trying to connect those dots as much as you can. Maybe I'm accepting something because I know that there's someone, maybe every client doesn't need adult diapers, but I know that there's several families that do, so I'm gonna take that pallet, and then I'm also gonna work with another organization to make sure I get it to whoever needs it. So I think that that's really been one of the nicest builds. We moved into a new space that we've been fundraising for years, and we've worked super hard to be as organized as we can so that there's a lot of intention to our donations and to what we receive and what we trickle out to other orgs. And other orgs are really willing to help us. People do, like, in spite of all the xenophobic rhetoric, there are a lot of bright spots and a lot of folks that want to see others succeed.
It's flashing red, I don't know if that's important. But with the Bumblebee Foundation, you guys can fill in any gaps I forget. Their main priority is to help children with disabilities, and we have a good amount of children with disabilities living in shelters. So personally, I have a cousin who has cerebral palsy, so even growing up with her, she's 19 already, growing up with her and seeing all the struggles she had to go to, even to get to Chicago Public School, which offers special needs program, and that's that my aunt speaks English, single parent, she has a job, and she has a support system around her, all my aunts, my grandma, me. That day of the Bumblebee Foundation, we had a day where we had physicians, ophthalmologists, and just people there helping. In order to get into these Chicago Public School special needs programs, I believe you have to have a diagnosis of the disability and a multitude of other things in order to even start the process. So MMHT partnered with the Bumblebee Foundation, and we had a day where we transported the children with disabilities into a hotel, or what was it? Exam space.
And then you had to walk to the other school.
Yeah, it was like an exam space, and we just did all the necessary things we had to do in order to speed up the process to get these children into like the necessary special needs program within the Chicago school. And I think that in itself is a success story. Being able to speed up the process and being able to aid in that process was really important.
Yeah, thank you so much for sharing your experiences, and this just helps us be more aware and be more intentional in the support that we provide as a community. So with this, I open the floor to our audience. If you have any questions for our panelists, please feel free to ask them at this time.
I first want to say thank you for all of your service, your commitment, and your passion. Um, so this might be a kind of a two-part question. So how has this shaped your outlook with your involvement in the medical field? Because in the news, you hear about physician burnout, especially after you're going through a 100-year pandemic. And you have been on the front lines even more so of seeing the shortcomings of healthcare. And I ask this of all of you in the different places that you are, those who are about to enter, those who've been in the field for a while, and I guess also the emotional intelligence side, like how do you care for yourselves? How do you care for yourselves now? And how has this shaped the way that you look at the medical field as you venture more into it or have been in it for a substantial amount? for so long. It's only because I know you. I'm not trying to age you or anything like
I
that.
know, it's okay. I feel it.
So that is my query.
I guess I can start. I mean, personally, I think it's really geared me more towards a community-based medicine and trying to make sure that I'm training myself to like practice in non-traditional settings, under-resourced settings, because it's really here. In the U.S., we don't have a perfect healthcare system. It's far from perfect, and we're going to have to be doing more outreach than I think people consider when they're going into the medical field. But I think it's also really like driven me more. And then to your second question about how we're taking care of ourselves, I mean, we've had to tell some of our core volunteers that they need to step back. I think it's really hard for people, especially if they have their own lived experience of immigration, to say no to this work. But we try to keep a lookout for each other. And if anyone is showing signs that they're overwhelmed or burnt out, we try to get ahead of that and have a conversation with them and make sure that they can take time for themselves. And then we've recently also had one group mental health consultation session so that we can share our own experiences, kind of like group therapy if you've done something like that, specifically designed for people who are healthcare providers. And I think that's been a healing experience for a lot of us, and we want to continue doing something like that because we know we're going to need it.
I'll be the first to admit that as I've participated more and more and gotten more entrenched into medicine, and now on the precipice of actually starting to practice it, it's a little bit like seeing the sausage get made and being like, I don't think I ever want to see that again, kind of thing in some ways, and then in other ways I've witnessed some of the most remarkable shows of compassion and kindness, and not even necessarily from a medical person, but just within a medically difficult situation. I think as an example in terms of moment of intense burnout and intense sadness and anger, and sort of showing how I came out of that specifically was in the last couple of months when the 5-year-old who passed away, John Carlos, in the Halstead shelter, when that news broke, I think several of us will probably agree that broke a part of us too. It was an incredibly preventable issue. It was not handled with care. The family was not treated with compassion even after the fact. And as sensational as any news story that came out may have been, sitting in that anger and that sadness when MMHD went to his vigil, and hearing the heart-wrenching sort of accounts from the individuals who were either there or who knew the family, who had known him, in one sense made me want to just pack up and that was it, because I couldn't understand how that could have happened in this first world place, in the place that was supposed to or at least should, whether they were supposed to or not supposed to, this is the bare minimum of not letting something like this happen. But then on the upswing sort of was the fire in the belly that has become renewed with a sense of urgency and a sense of passion that is fueled by how unfair and how unjust and how horrible that was. And trying to just pick yourself up and band together and look around and realize that I'm surrounded by incredible people, like-minded people. There are more than I'm sure even this room could even contain, who are willing to put in the work and who are willing to be there for each other in the sadness, but also be there for each other in the fight and in the struggle. And I think that's kind of the two-sided coin for me.
Brian, if I may ask this, I know that match, I used to work with maybe that was all the time. Did it shape your method, the match journey?
It did, actually. I came into medical school very certain that I wanted to practice in a pediatric space or like work with kids. And then MMHT was one of the main motivators to want to care for all ages. And so that's kind of what pushed me into internal medicine and pediatrics, which was where I've meshed. And I think it was a matter of inclusivity. Like I just wanted to know from all spectrums and all genders and all walks of life and everything. And then it was something that caught me by surprise. Quite literally, I did not make my official decision until maybe a month before my application was due.
You know, there's a really specific definition for burnout. As a previous residency director, I used to make the residents do burnout surveys every February, which is a really awful time to do it because it's dark and you're just exhausted, but it was helpful. And I used to have the residents do a personal and professional mission statement so that they could try to remember who they were and to stay grounded, because that's really important for your dark times. So the Maslow burnout survey defines self-efficacy, exhaustion, and depersonalization. And they have 3 things that they do with that. So I think I'm always exhausted. Like I could stay in bed all day, every day, and doom scroll if you would let me. But I never turn off. So, and I'm a night owl, so that doesn't help. So I want to stay up later than I'm supposed to stay up, and then I pay for it because I have a 7:30 meeting or something. But the depersonalization, I don't think I do. I think I'm a lot more pragmatic than I was before. Those spaces and those instances, you need to remember that. We're not, like any other profession you go into, medicine kind of sterilizes people, right? They talk about the 55-year-old blank or this person this. If you're doing case law, they talk about people, this versus this versus that, and how it changed something. So I like holding on to those anecdotes about my patients or the patients I encounter because I feel like that's real and it grounds me. And I don't want to get caught up in the rhetoric. So that helps me stay very, very focused on what's important. And then the part with the self-efficacy, well, that's easy, right? Because we know what we're doing makes a difference. And you have to pace yourself. They say it's not a sprint. It's not a sprint. It's a marathon, right? And you have to remember that. That's been hard for me. Now I'm 50, so I think I accept that a lot more. 5 years ago, Steve Brown, who does Better Health Through Housing at the hospital, which is like the hot spotter program that gets people that keep getting admitted basically because they're experiencing homelessness. I remember him really talking me off the ledge years ago and saying, you keep thinking you're going to fix stuff in 5 minutes, and the system's been acting this way for centuries. So you have to really focus and just accept that things aren't going to change as fast as you'd like them to. And the thing that really has bailed me out is starting a nonprofit. As tired as I am to do it, it is so nice to be able to flip a switch. When Sadi Scaldo came to my dining room to talk to me about MMHT, I said, well, I can help you with that. It won't be with my UI Health hat, It'll be with my nonprofit, because I can just jump the fence and go do it that way. Or last week when I was on hospital service and we had a gentleman with measles who was too well to be in the hospital, but there was no isolation space at our city shelters. I was able to take money from our migrant fund and put him in a Holiday Inn for one night, so that one person in the emergency room would not be boarding in the emergency room. And this seemed like a very silly way to spend $125, but I know from taking care of patients how dangerous it is when you board people. So that little thing helped me feel better that day, that I was doing something. And then being part of hospital leadership, the nice thing is I get to be in a room where I can speak truth to power, and I've been elected by my peers. So it's not some appointment, it's the medical staff elected me because they like someone who's just who's unconventional. I even dressed up for you all today, which I don't normally do. They know I'm always in a t-shirt, but I tried really hard today to look like put together for you. But it's because it's a lot of it has to do with that. It's like that trying to help people, and those anecdotes, those stories change how people think about things. I spend a lot of time talking to the press and trying to give an educated account of what I didn't talk about, the solar eclipse and effects on menopause last week that Univision asked me, because I said I knew nothing about that, and I'm not going to claim I'm going through menopause, even though I am, so I'm not going to do that. But I really like to be able to tell people that the only way people are going to change is making that connection. Otherwise, it's all stereotypes. There was this really neat ACLU map that I used at the American Medical Association this morning, and it showed that 2/3 of our entire population lives within 100 miles of every border of the United States. So there's this just like permafrost, that's like all around everything, and it's all in, and so we see things only a certain way, and we really need to, contribute to our diversity. The United States is really like 50 countries or 11. We've seen these things they talk about, and it's really real. So, but that takes time, but that makes me feel better. Like, I would just much rather try to understand as much as I can understand and try to do the best I can in my little bubble, and then keep being inspired by the generation that's going to fix everything.
So I didn't get to dress up today. I thought today would be a normal day of classes.
There's nothing wrong with that.
I'm here. Yes,
Sorry,
I'm
I
here.
didn't mean it like that.
No, that's-
Also, some of the advices pre-med students still stop being self-deprecating.
Yeah, don't be self-deprecating.
Okay. But from the undergrad perspective, you could be burnt out with school, with organizations like clubs, etc. But I feel like we're under a protective layer. So the med students, physicians are taking most of the hit, and we're just here being happy we're here. But I've always romanticized medicine, and all the times I've been in clinics, there were some disheartening stories, but overall it was a clinic, it functioned, it was a well-going clinic, and then I always feel like you have to burn the system and rebuild it in order for it to work. But being with MMHT really opened my eyes. It didn't really stray me away from medicine, but instead gave me another purpose. So instead of maybe just being like, Dr. Figueroa talked with Medicina scholars, had a talk, and then I was like, oh my God, this is so amazing. And then I volunteered at the food pantry. But if anything, I think I haven't really experienced burnout, but it's the work MMHT has done really has inspired me to continue the work, if that makes sense, to continue trying to reshape the work, if at all possible, in the future. So it's just been inspirational and really great.
Yeah, thank you so much for sharing, and thank you for your time as well today. And I just wanted to tell you that all the work that MMHC does, I hope today taking this time to have this discussion has inspired you to, as an individual and also as a part of our Chicago community, to support the work they do and try to be a change maker yourself as well. Thank you so much once again for your time. I'll hand over to Dean Boyd for closing remarks.
Thank you so much. Thank you everybody for coming. We do have some items here. Unfortunately, I
Don't worry,
okay.
we'll figure it out.
Yes.
So, as a thank you for coming today, just a little token of our appreciation. Let's give them another round of applause. And we hope to see all of you at our next event. We're going to have another one in the fall as well. Please help yourself to what's in the back. Thank you.
Thank you so much.